And thanks very much, everybody, for spending your Saturday morning with us. And I'd like to talk a little bit about some stuff. A lot of this is maybe a little bit futuristic because a lot of it's not quite yet ready for prime time. But I think it's the direction that we're going in, and I think it's something that will be used more and more over the course of the next 5 to 10 years. And so this is sort of the introduction to it for all of us. So these are just my disclosures of the various grants and other things that I have. So a little bit about where we are today with regard to MS therapy. As that many of you know, the first interferon beta serum became available in 1993, and then there's been a series of other medications, with most recently teriflunomide or Aubagio being approved just a few weeks ago, and several others sort of on the launch pad, and there's actually quite a few beyond this that perhaps Dr. Wyner will be speaking about. But it's been an incredible pace. I actually happened to get out of my fellowship in 1992, and we had 0 medications available. So the pace of the change over the course of the last 20 years has been nothing short of remarkable. But where we are today is that we have a variety of different medications. The question is, how do we use them? In a sort of standard fashion, many individuals think about so-called first-line therapy with the medicines that we've known and used for many years, Avonex, Betaserin, Copaxone, Rebif, which have been available for up to almost 20 years now, and with their various good points and bad points noted here. And the so-called second-line therapies, the newer medications, natalizumab, fingolimod, mitoxantrone, and now teriflunomide, as well as off-label medications, which generally have been used as a second-line agent, and in fact, second or third-line agent. And in fact, there's been almost an institutionalization of this. That is, Medicaid in Colorado and Wyoming require, for example, that before you use natalizumab, you fail at least one of the first-line agents. They require that you fail at least 2 of the first-line agents to get fingolimod, at least glutaminyl acetate and 1 of the interferons. A lot of the private insurance companies also have so-called step therapy. And the step therapy is based on primarily cost, questionably on safety, although I think that the patient and the doctors are quite able to judge safety issues amongst themselves and don't need an insurance company to tell them that. But the choices are otherwise often based on what might be thought of as relatively random things, like the number of shots per week, whether or not there are flu-like side effects and things like that, but not really been based terribly much on effectiveness and not really been based on markers that might be able to tell us, well, this person might do better on interferon, and this person might do better on glutaminyl, and this person has a higher risk, say, with natalizumab. And we're only starting to do that now, and that's what we're going to talk about a little bit. So the logic for a new paradigm, I think, is sort of the following here. Untreated, I think we know that many patients, most patients, do develop some level of disability. So I think we really do need to treat, and we need to treat aggressively. Older therapies are partial at best, and I would say actually the newer therapies are partial at best as well. Older therapies are all about the same efficacy, and multiple studies have shown this, and I'll show you some of that data today. The thing I'd like to stress is that the first 5 years matter, and I'll show you some data about why I think that that's the case. We can identify a significant number of patients at high short-term as well as long-term risks, and for example, Dr. Bennett was just describing one of the ways that we might be able to measure that using OCT, but MRI scans and other things might be able to tell us about that as well. So that is, we might be able to identify those individuals who we might even want to spend more energy and effort on up front to try to reduce problems early. There have been a variety of different comparative trials now, and most of the time when the older medicines have been compared to the newer medications are somewhat better. And then finally, we need to identify responses to and risks associated with the medications before the use or during early use, but not after the fact. Finding out that someone has had more attacks after the fact is not very helpful. We want to know this information before they have attacks. So this is old epidemiologic data from Brian Weinschenker when he was back in Canada. He's now at the Mayo Clinic. And this is a study just of natural history of MS, showing that the majority of patients untreated, because all these patients, this was published in 1989, all these patients were untreated by definition, that the majority of patients will progress to disability over time. So they use the old DSS, now the EDSS, the Extended Disability Status Scale, a 10-point scale that we use to define the neurologic exam and disability in MS. And 6 means you need a cane to walk. So generally that's an easy thing to define, people can remember it, and it's obviously a significant change for someone when they need to use a cane to walk. And the numbers are that by 15 years, about half of people untreated will have to use a cane to walk. And in fact, that's taking all comers, but actually they then followed also people that were actually followed from the onset of their disease as opposed to just retrospectively looking at this information. And actually in that population was actually maybe even as early as 10 years. So a significant number of people will develop disability, and we're trying to avoid that. And that's the logic beyond anything else why we want to try and intervene early. This is just a slide that many of you have probably seen over time, comparing the original ABCR drugs to one another just with regard to the annualized relapse rate, showing that essentially there's a reduction compared to placebo of about 1/3. These are all different studies, not within one study, but they all show pretty much the same thing and show that this is a partial effect. It is not a complete effect from these medications. And there have been a variety of more formal comparison trials where you compare within one study various medications, and they're listed here: Beyond, Become, Regard, and the recently not yet published COMBARE-X trial, which compared interferon beta-1a Avonex to glutaminyl acetate Copaxone versus a combination of the two together. And what these studies have shown overall is that these medications are relatively similar to one another. This is just one example. This is the Regard trial, showing that the numbers are quite the same with regard to the risk of having another attack. The annualized relapse rate and other measures are really quite similar between, in this case, interferon beta-1a Rebif and glutaminyl acetate or Copaxone. Similar studies were done in comparison with beta-seron as well. This is the not yet published COMBARE-X trial, showing that they used to measure where you combine whether or not somebody changed on the EDSS, whether or not they had an acute attack or relapse, as well as whether or not they had any new lesions on their scans. And so this was a combined, unique sort of activity, both radiographically as well as clinically. And you can see the two medications were not terribly different. And actually, interestingly, these are the patients who were free from new disease activity. Only about 20% were free at 3 years of disease activity when you counted it that way. People did slightly better with the combination. Almost all of this was driven by differences in MRI scans. Clinically, there was very little difference between the two, although the medication on relapse rate slightly favored the Copaxone. So the medications, although we're very happy to have them, they've been partial medications, and I think all agree that we need better medications. And in the first 5 years, I'm going to show you some data why I think it's extremely important to treat very aggressively. We know that relapses are most common shortly after onset of the disease. We know that relapses frequently produce disability itself. That is, that they'll leave a mark. MRI, which we now have been using for 20+ years, helps predict that, and now I think the OCT will also help predict that as well. And as Dr. Bennett mentioned, brain atrophy extremely important, but also the so-called dark holes or black holes on T1 imaging and the T2 lesions. Those predict disability in the short run as well as in the long run. So we have some markers to help us identify individuals who are going to have difficulties in the first 5 years. So this is from a different Canadian natural history study, but others have shown the same thing. And this just looks at the relapse rate for men and women from the onset of disease by current age, and then also by years since onset. So here's age, and here's by years since onset. And the thing that is notable is that right after you're diagnosed, that's your highest risk of having more attacks. And over time, the attack rate goes down. In addition, you can see just by age, there's a peak in the sort of the 20 to 30 range, and then again, the rate goes down over time. Why exactly this happens is not clear, but it's a simple reality that the highest rate of disease activity is early on in the course of the illness. In addition, when you have an attack, a significant number of those attacks leave a mark. In this study, this is from Fred Lublin in New York. He was looking at a combination of a variety of different patients who were in the placebo arms of different clinical trials, and found that over 1/4 of patients had a significant change, that is 1 point or more on our 10-point scale of EDSS, with just one attack. And there's a variety of other data from other studies that shows over time, on average, anywhere from 20 to 30% of people will change over a 2-year period of time, at least 1 point on this scale. And that goes along with that very first slide I showed, showing that disability accrues and it starts from the beginning and it's persistent. We also know that we can actually predict those people who are at highest risk. It's not perfect, but we actually do pretty well with just MRI scans. So this is from a study by Darren Akuta, and this is for patients who haven't even had a clinical attack, so-called radiologic isolated syndrome, individuals who have a reason to get an MRI scan that has nothing to do with MS. Maybe they had a migraine, maybe they were in a car accident. But they get an MRI scan, and lo and behold, it looks like they have MS. And then he started looking around at other things. That would be a brain MRI scan. Started looking at aspects of the brain MRI scan or aspects of other MRI scans and spinal fluid and other things to try to determine, is there anything that can predict risk of actually having clinical disease activity? And a variety of things were looked for, but notably, if you have an abnormal brain scan and you've never had a clinical syndrome whatsoever, if you have a cervical spine lesion at the same time, for which you've also had no clinical symptoms because you didn't have that, that's not why you got the MRI scan in the first place, your risk of going on to have a clinical attack in the short run is a 128-fold increase. That's a tremendous increase. Your risk if you have a lesion in the lower portion of the brain, what's called the posterior fossa, is increased almost 10-fold. So these are simple things, even in people who've never had any clinical activity, that are predictive of having clinical activity. What about someone who's already had at least one clinical attack? And all of the different pharmaceutical agents have been studied in this context. This is the first of those studies, the so-called CHAMPS trials done with Avonex. And they looked at the data over time and said, well, what are the things that over a 2-year period of time predicted someone having a new clinical attack? Because that was their main outcome. What was the likelihood after one attack you'd get a second attack? And they compared Avonex versus placebo to see that the Avonex retarded that effect, and in fact it did. But having 2 or more enhancing lesions on your brain MRI scan at baseline made it 50% likely that by 2 years you were going to have a second clinical attack, and it was a very high predictor. So having a lesion in the lower portion of your brain or in your spine, or having an enhancing lesion, an active lesion, both of those predict short-term clinical activity that's new. What about just looking at your baseline MRI scan in a similar context? People relatively new with their MS. If you just look at the very first MRI scan and you look at whether or not these patients fulfilled what we used to use all the time, the so-called Barkov criteria to help define MS. Now we use slightly different criteria in the so-called McDonald criteria for MS. But if you had certain criteria, 3 or 4 of the 4 criteria for Barkov related to the diagnosis of MS, your risk of developing significant disability over just an 8-year period of time was 4-fold increased. So that's just having 3 or 4 of the classical criteria that just define whether or not you have MS or not. On the same thing, looking at the very first MRI scan, can you predict those individuals who will go on to this using a walking stick, EDSS-6, or having a moderate disability, at least one of the multiple things we measure on this EDSS, just looking at the very first scan. And this is looking at the so-called burden of disease, the little white dots, if you make them all up into one volume, do those predict going on to have disability? And this is over just a 10-year period of time. And in fact, they do. So if you had no abnormalities at all on your MRI scan, your likelihood of going to a walking stick, this is after a first attack of MS, just an optic neuritis, a transverse myelitis, any of those first attacks. If you had a normal brain scan, your risk of going on to having a walking stick at 10 years was virtually none, 4%. And having moderate disability in one aspect of the exam, maybe almost 20%. But look what happens as you go up. If you have a small lesion volume, that is a small number of the white dots, still not much of a risk, but still almost 1 in 5. But if you have a significant number of MRI scan lesions on that very first scan, that's highly predictive. Almost half of those people at 10 years used a walking stick. So we know that that very first scan can be quite informative. From the same group of patients studied over time, this is the 20-year follow-up of those same patients. And what happens? The people that develop more of those lesions in the first 5 years, those are the patients who are much more likely to go on to become what we call secondary progressive MS, where a great deal of disability occurs. Whereas those people that don't accumulate much in the first 5 years, in fact, they have a much lower risk of that. So the first 5 years are not only predictive of using the MRI scan, predicting of clinical activity, but also predicting of how people are going to do in the long run. And this is just a study from the same thing showing a significant correlation between that accumulation of the lesions as well as the amount of disability on the EDSS, showing a highly statistically significant correlation between those. So development of more brain lesions is predictive of what's going to go on over time. How about after people start to get treated? Does the MRI help predict there? It does help predict there. We know this is from the so-called Prosperini article. He was the lead author on this article. And they looked at patients who were newly diagnosed, started on interferon, and then followed for 5 years. And they said, okay, well, what happens to people who did well compared to those who didn't do as well? Are there any things that happened, either at baseline or in the first year, that helped predict those people that did not as well? And in fact, if you had just a single new little white dot on your brain scan, that predicted the likelihood of changing 1 point on this EDSS scale at 50% versus almost nobody who had no changes on their MRI scan the first year. If you had 2 lesions, it was 70%. If you had 3 lesions, it was over 80%, showing that if you had 3 or more lesions on your scan at 1 year, that was highly predictive of going on to have a change in your examination over a 5-year period of time. So before you ever have symptoms, after your first set of symptoms, after a full diagnosis, after you start being treated, the MRI scans are predictive and are helpful and can help us identify those individuals who are going to have more trouble versus less. And this all happens in a relatively short period of time. The first 5 years really matter. And also, as Dr. Bennett was noting, atrophy, perhaps our single best measure of defining disability over time or correlated with disability over time. This is brain atrophy. Over an 8-year period of time, if you look at the first 2 years and changes in brain atrophy over the first 2 years, and then see what happens to people 8 years total later, 6 years after that first 2 years, the change in the brain volume, the atrophy that develops in that first 2 years, is highly predictive of going on to have significant disability, that is reaching EDSS-6, again, using a walking stick. And over 50% of people, by 8 years after starting the medications, happen to be with Avonex or being in placebo. They actually combine the patients. If you had significant changes in brain atrophy in the first 2 years, that predicted that. So that's another marker. There's all these markers that happen in just the first year or two, or even before you have symptoms, that are predictive of having problems over time. So if that's the case, we should use therapy. And I think everybody probably in this room agrees, perhaps some don't, but most people, that the therapies have been shown quite convincingly, quite clearly, to alter some of these dynamics, to alter the natural history, to improve these things. But how, when we start to compare these medications, do they do when we compare them to one another? I showed you one comparison trial, the ones from the first-line agents compared to one another, glutamin acetate versus various interferons, and they were all roughly the same. Well, what about some of the newer agents? Well, this is the fingolimod trial, the Transforms trial, originally a 1-year trial, and it's extended to a 2nd year, comparing against interferon beta-1a, Rebif, and on multiple measures, the annualized relapse rate, on the number of patients who are relapse-free, the fingolimod at both doses that were studied, both the dose that is not being used clinically as well as the 0.5 milligram dose that is being used clinically, were superior to interferon beta-1a. Dr. Vollmer will be talking about a variety of different medications. I'm just going to show you a little preview from one of them, so-called BG12. And BG12 is a medication that's similar to a medication called Fumiderm that's been used in Europe, primarily Germany, to treat psoriasis for years. And it's been studied now and is sitting in front of the FDA, hopefully to be passed favorably in the next several months, in the early part of 2013. And in the original so-called DEFINE trial, it was compared to placebo, and it was clearly superior to placebo. They did a second trial called the CONFIRM trial, and they compared it again to placebo, and all of these numbers here are compared to placebo, but also in an open-label fashion, compared it to glutamin acetate. And on a number of these measures, and this was given twice a day or 3 times a day, and on a number of these measures, and the red stars are where it was superior to glutamin acetate. They were all superior except for this disability marker compared to placebo, but more notably, there were several comparisons that were favorable for BG12 compared to glutathione acetate, including both clinical measures like the annualized relapse rate, as well as MRI measures such as the number of T2 lesions, which we know is important. I didn't show you data about the dark holes, but that's also extremely important, also was better. There are some other medications you'll be seeing some data about. This is a medication that may get approved as well in the early part of 2013. This is alemtuzumab, or Lemtrada. In the so-called CARE-MS trial, CARE-MS-1, these were patients who had never used medications at all, who were relatively slightly younger. These are patients who had had disease onset no more than 2 years after, before they started the medication. And again, this was compared to interferon beta-1a, Rebif, and alemtuzumab, which is taken by vein in several injections over several days and then repeated at 1 year. And compared to interferon, it was 55% less annualized relapse rate over 2 years. That's a significant improvement. It's very similar to a prior study they had done also comparing to interferon. In addition, they have brain atrophy data suggesting there was more brain atrophy with interferon compared to with the alemtuzumab. In so-called CARE-MS-2, a separate trial but done in a very similar fashion, they compared patients who had already been on various medications. So these are not treatment-naive patients. They're a little bit older, had disease activity for a little bit longer, and had already tried a variety of different medications. And then again, they looked at patients, percentage of patients who were relapse-free favored alemtuzumab by 20% roughly, about a 47% risk reduction. If you look at this, the analyzed relapse rate, again, was significantly lower compared to the interferon. And this is the interesting data, I think. If you look at the change in the EDSS, generally if you have a higher EDSS, that means more disability. So less EDSS would mean less disability. That is, you actually got better. And they actually have the mean change in the EDSS was actually people to get better. It wasn't a huge change, but not only was it stable, but on average, and this is several hundred patients, they actually got slightly better compared to slightly worse with the interferon. And if you looked at the 6 months sustained reduction in disability, again, 2.5 times as many patients actually improved on the EDSS. And then on the more standard measure, the number of people who actually worsened, there was a 42% reduction in those who actually worsened on that scale as well. This is another medicine you might hear a little bit about, ocrelizumab. This is very similar to a medicine called rituximab, which is on the market to treat other disorders, but not to treat multiple sclerosis. Roche Genentech, which owns both molecules, is actually developing ocrelizumab, perhaps a slightly safer molecule, but a very similar molecule, works very different from other molecules that we use. And in a very complicated study, they compared patients who started with different doses of ocrelizumab, which is taken by vein twice every 6 months, versus placebo versus interferon beta-1a, and this was Avonex. And over 6 months, that's the way they did it. After 6 months, everybody went on to ocrelizumab. So the only part that was controlled in a comparison was the first 6 months. But what they showed was that very rapidly, this is gadolinium-enhancing lesions, the so-called active lesions or inflammatory lesions. Within 8 weeks, the patients who took the ocrelizumab, those are the 2 lines down here, essentially went to 0. They had no new active lesions. Whereas the placebo and the interferon beta-1a were hanging out about 1.5 on each one of the monthly scans. This was very similar to the data that was seen when rituximab was studied in relapsing patients as well. So that by 8 weeks, essentially, you go to 0 disease activity with ocrelizumab. What about natalizumab? Very commonly used, been available back on the market for over 6.5 years now, almost 6.5 years. But there are no head-to-head comparisons with natalizumab or Tysabri compared to any of these other medications. Comparisons between studies seem to favor natalizumab when we compare them to the interferons or glutathione acetate, but we don't have any real data that proves that. Our anecdotal experience would also probably argue that that's the case. And there's also a phenomenon that doesn't really occur with the other medications. We know that when patients, especially those who had a significant amount of disease activity before they went on natalizumab, when they go off, there's a significant rebound of disease activity, suggesting there was an incredible suppression of disease activity that was going on. There's also numerous studies showing that quality of life and related symptom checklists are actually improved in patients on natalizumab, and that data does not really exist for any of the other medications. So although we think in many respects natalizumab is perhaps superior to these medications, we really don't have any studies that prove that other than what we have here. But there is an interesting study called the TOP study. It's just an observational program, primarily in Europe. There's now almost 4,000 patients in 15 countries, and they're just monitoring patients over time. And interestingly, they have about 9% of these patients who were never treated before with any other agent, and the other 91% had used at least one agent. And when they looked at those, the treatment naive or TN patients were a little bit younger, about a year and a half younger, a shorter duration of disease, 2 years versus 8 years. They had a slightly lower EDSS, but actually not terribly different, almost identical, and a similar annualized relapse rate. So they were a little bit younger for sure, and they had a shorter disease duration, but otherwise clinically they were pretty similar to one another. So what happens when you compare those who were treatment naive compared to those who'd already been on other agents and were a little bit older? Well, they both dropped their relapse rates substantially from an average of 2 to almost just a quarter per year. That's a dramatic drop, very similar to what was seen in the clinical trials. The probability of relapse by 1 year, or by year 3 rather, favored the people that were treatment naive. That is, only about a third of those versus almost half in the patients who had previously been treated. And again, the EDSS was lower, improved over time in the patients who were treatment naive, and these differences increased over time. So the number of patients and the amount of improvement was greater in those who were treatment naive. And then if you look again at the way of just counting that, the risk of improvement was 30% over a 3-year period of time versus 20% for those patients who had previously been treated. This is good for both of these, but it's even better for the people that were treatment naive. So getting to them sooner, getting to them younger, had a beneficial effect. So, is it time to think differently about these medications? And is it time to start thinking about how we use and choose and pick the medications that we use? So, would it make more sense to treat with the most aggressive therapies when the disease is most aggressive, at the outset? Not make people fail medications that are seemingly not as effective on various different studies. Why should we not use the more effective therapies first, when people have more active disease? And then transition to so-called safer medications when the risk of the disease itself is similarly lower, that is later. And approaches could be then stratified. Could we stratify by disease severity? Can we pick people who we are more worried about compared to less worried about? Could we pick by risk issues, as we do, and I'm sure many of you know about using the JC virus serology test. Can we use other things to help define risk issues that would help guide us as well? What about futility of therapy? We know that various medications stop working, and sometimes they stop working because the immune system develops antibodies against those drugs. Can we use those more effectively? Can we predict the response to therapy? That's actually an incredible talk all by itself, and I'll only touch on that briefly, showing one example of how we might be able to do that. And then finally, can we predict ahead of time those individuals who are likely to do well with drug X compared to those who are likely to do well with drug Y, and actually give them a drug not based on number of shots or if it's oral or something else, but based on how we think they're going to respond to the medication, because that would be obviously more important. It wouldn't be the only thing that's important, because using the drug is important as well, but it'd be more important. So these are the things that we might be able to use, so-called biomarkers, beyond the MRI scan, using the MRI scan as well, but using so-called biomarkers so that we get to what we think of as more personalized medicine, choosing for any one individual a medicine that seems to fit them better. And it'll be based on all of these kinds of different markers. So I'm going to give you some examples of these now. These are the things that we know already are generally either unfavorable or favorable prognostic risk factors for patients. And there's a whole host of things based on age of onset, if you're black or if you're white, if you're male, if you're female, the types of attacks you had, if you develop disability over time, MRI measures and other things. We use these all the time. And these help define severity of the illness and risk over time. And I've showed you multiple of the markers for MRI scans that we use. But there might be other things as well. And can they help us define things even better, to define risk of having severe disease early on, even before you ever use a medication. So the MRI we already used, but I'm going to show you a couple examples of perhaps even using either some blood or some spinal fluid markers that perhaps would be helpful. So this is an example of so-called IgM or lipid-specific IgM bands. Now, many of you may have had a spinal tap at some point in the past to look for so-called oligoclonal bands. Those are IgGs or immunoglobulin Gs. There are multiple different classes of immunoglobulins. In fact, Dr. Bennett's one of the world's experts on that, although he didn't talk about that this morning. And, but you can look at different classes. And for many years, it's been known that perhaps the IgM markers are perhaps a better marker of disease activity in the short run and perhaps in the long run. But they've not been as useful clinically for reasons that are not totally clear. So this study, which was published a couple of years ago, looking at those individuals who had the IgG oligoclonal bands, as well as these so-called IgM oligoclonal bands, compared to those people that didn't have either one of those. And then looked at those patients to say, okay, well, what's the likelihood that you're going to have a relapse? The probability of remaining relapse-free, so that you would like to be up here. That is, you don't want to have a relapse. And so, what is this group? This group is the guys who don't have either one of those. They don't have the IgGs or the IgMs. Well, what about the people that have the IgGs but not the IgMs? Well, they're in between. What about the people who have the IgGs and the IgMs? They're here. That by 2 years, essentially 100% of those patients had had a second attack. Whereas if you didn't have either one of those markers, at 12 years, 90% had not had a second attack. So that's an incredibly powerful marker. That's going to tell you if you're going to have another attack or not over a prolonged period of time. Does that correlate with other MRI markers? And in fact, it does. If you look at the so-called T2 burden of disease, the white dots made up into one volume, those people that had a combination of both of those sets of bands versus just the one, just the IgG bands, versus none of the bands, the people with none of the bands remained very low. They didn't really gather much in the way of any accumulation of these white dots. But the ones who had both bands, a significant increase over time. Does that also correlate with progression of disability in over a 14-year period of time? It does. Those people that had the IgM bands were much more likely, this is the higher IgM index, much more likely to have a change in their EDSS. So it correlates with other MRI markers, and it correlates with disability markers. Can we use this to help define nature of severity of disease? In addition, this was just published 4 or 5 weeks ago, 6 weeks ago. Dr. Wyner and his group in Boston looked at so-called RNA profiles. So the dictum of molecular biology is that you have the DNA, the so-called code, it makes RNA, and then the RNA becomes protein. DNA becomes RNA, becomes protein. That's the way it works. So we talk about RNA expression, and these RNAs are sort of the controlling molecules that say, make this, don't make this, and they control, turn this on, turn this off, in terms of making the proteins. They're extremely important, and RNA expression may change within a cell. It may be different from cell to cell. It may change at different times within a cell. It's the way a lot of these medications that we use probably work, by altering RNA productions. So what they did is they tried to develop a profile of expression of a variety of different RNA markers. And they said, okay, are any of these informative? Can we take some of these and say, well, if you have high expression in these 6 or these 10 or these 30 different markers, do you have more severe disease versus less severe disease? And that's in fact exactly what they found. And they identified that the so-called MSA group had more severe disease. And in this case, they were counting a kind of combination of attacks, a change in EDSS, or any change on the MRI scan. And if you had any of those, then they called that more severe disease. And they had a group that was less severe, so-called MSB. So the MSA guys had higher expression, interestingly enough, of white blood cell or lymphocyte activation pathway genes. These are the things that we think are involved in the acute attack of the MS. So not surprisingly, the expression of the molecules associated with this were elevated in people that had new disease activity. And when they looked at the therapy response, both with glutathione acetate and interferon, it was actually statistically significant with glutathione, but not quite with interferon, that the treated groups had more new activity in this group versus the B group. That is, the ones that responded. So there might be a treatment effect associated with the two, but they primarily showed that there was in fact a difference. They could pick out the severe patients from the less severe patients by looking at so-called RNA profiling. So that has to do with disease severity. What about risk of therapy? And many of you may have tried natalizumab. Many of you may have already had your JC virus serology checked in your blood to see if you're at risk of developing the severe complication called PML. And, but there's also, with alemtuzumab, I'll show you, alemtuzumab is a new medication that may or may not get approved in the spring. Is there a marker for that? And I'll show you why that would be important in a moment. So with regard to PML, we know that the overall risk, this is as of September 5th. I didn't put the October date in, but it's very similar. The overall risk of developing this complication with natalizumab, Tysabri, is about 2.63 per thousand in anybody who ever uses the drug. But we know there are several things that are associated with the risk. One is just how long you use the drug. So if you use the drug longer in the 3rd and 4th year, the risk is higher. Actually 3rd, 4th, and 5th year probably. The risk is higher than in the first 2 years when the risk is actually quite low. But we also know that prior exposure to chemotherapy or immunosuppression, that also is associated with your risk. And we also know that having this blood test being abnormal or not is associated with risk. So you can stratify patients according to their risk. So first of all, just check to see if that person has been exposed to this virus or not. If you've not been exposed, your risk is very low, reflecting that the test could be wrong, although it's not usually, and that you could be exposed to the virus at some point in time. That is, you could seroconvert. But what if you've been exposed? If you've used prior immunosuppression or prior chemotherapy, this is no, this is yes, and this is the duration of time, 1 to 24 months versus 25 to 48 months, you can see there's a dramatic difference in risk. The patients who only use it for 1 to 24 months and have not been exposed to prior chemotherapy, even if they've been exposed to the virus, they only have about a 0.56 per thousand, or a 1 in 2,000 risk in the first year, 2 years rather, of developing PML. In the first year, it's about 1 in 13,000. The second year, about 1 in 1,000, a relatively low risk. But look what happens if you have somebody who uses the drug for a prolonged period of time and has prior exposure to chemotherapy, as well as prior exposure to the virus that causes this complication. Then your risk is essentially 1 in 90. That's a dramatically different difference in the 3rd and 4th year compared to this person. So that this drug is not the same risk for everybody that uses it. It's dramatically different compared to if you're positive or negative, and then the duration of use and this prior chemotherapy. And there may be other issues. One of our colleagues in Utah, Dr. Foley, has identified that perhaps body mass may be related to risk as well. So there may be other risks. Perhaps smoking is a risk. We don't know all the different risks. So this drug may have different risks based on who you are and other things. And this is again notable, and just to bring up the age issue, over time people get exposed to this virus. This is the people who have been exposed to the virus over time. Younger patients under 30, older patients over 60, and it's actually higher in men than it is in women as well, so you can actually stratify this further by men versus women. But people under the age of 30 have a relatively quite low risk of having been exposed to the JC virus, whereas people over 60, a very high risk of being exposed. So would it not make sense to probably try and use natalizumab in younger patients when they're much less likely to have been exposed to this virus? So this is the alemtuzumab story. This was developed over the course of the last several years. And this drug is not yet approved, may or may not get approved in the spring. But it was clearly found very early with use of this medication that a significant proportion of patients develop autoimmune problems related to the use of this drug. And a huge number, relatively, up to 15 to 20%, may develop thyroid problems that need to be treated. Most of them can be treated simply, some not so much. And so the search for markers was set forth, and it was identified that IL-21 is a hormone-like substance. It's a cytokine made by white blood cells. It's a communication molecule. And there are many of them. IL-21, there's IL-1, IL-2, IL-4, IL-7, etc. Now it's up to, I'm not sure, I think it's up to about 30 or so. These are communication molecules between white blood cells. Say, turn on, turn off, go up, go down. And so what they identified very early in this study with Jones et al. was that this IL-21 seemed to be elevated in people who developed the autoimmune disorders that were seen when people used alemtuzumab. So this was followed up over time with a slightly larger, more sophisticated study comparing 42 patients who did not have MS and were not treated versus 248 MS patients, 63 of which, about a quarter of which, had what they define as highly active MS, and 43 of these were treated with alemtuzumab, so about 2/3. Not all of them were treated, some were, some were not. And they looked at the IL-21 levels. And interestingly, IL-21 correlated with disease type, that is relapse remitting, and the pre-treatment relapse rate. And those patients who had more active disease had higher IL-21 levels. And that is, there was a very good correlation between active relapse rate and the IL-21 levels, with the highest levels seen in those patients with so-called highly active MS. But then they also looked to see if the IL-21 levels were predictive of the actual active disease, and it was. And perhaps more importantly, it was predictive of those individuals who are going to get this autoimmune problem, with a sensitivity of 86%, that is picking up almost 90% of the people who truly did develop the autoimmune problem, and then specificity, that is excluding those patients who wouldn't. So as a marker, it was not perfect, but it was pretty darn good at picking up the true ones and rejecting the false ones. So as a marker, this needs to be improved. It has to be replicated. But if this holds up, this would be another marker similar to the JC virus test that would help predict risk of using a medication for a potentially significant side effect. So what about futility of therapy? We've known for years that interferon antibodies are associated with more clinical activity and more MRI activity. That is, your body will react with an antibody response against the drug. Not everybody gets it. In fact, it's a minority of patients who get this. But it's the only good reason we know that people actually do fail with using the interferons. That is, that they develop an immune response against the drug. Well, similarly with natalizumab, similar findings have been seen. So this is published several years ago by Peter Calabresi and others from Johns Hopkins, showing that individuals who had persistent natalizumab antibodies compared to those who never had antibodies had double the rate of a change on their disability status over a 2-year period of time. Having antibodies was associated with a much higher risk of developing disability. So if someone is failing interferons, or if someone is failing natalizumab, perhaps one of the reasons why, and perhaps the only reason we can really identify why, is that you've developed an immune system reaction against the drug. Perhaps the most important, though, is predicting response to therapy. Wouldn't it be great if we could draw a blood test or do some other test beforehand and say, you're going to respond really well to this drug and you're not going to respond well to that drug. So you should go on this drug because it's going to do a better job for you. And we're at the infancy now of trying to understand this. And there are a whole bunch of different approaches that have been used. So I mentioned RNA expression with Dr. Wyner's group with that slide just a couple of moments ago. That not only can predict severity, but people are using RNA expression of so-called interferon response genes. That is, genes that we know when you give interferon to a cell in culture, certain things go up or certain things go down. That is, they respond to the interferon. So if you could develop a panel of these RNA expression markers ahead of time to see how someone responded to the interferon and how that was correlated with clinical activity over time, that would be very useful, and a variety of studies have looked at that. What about excessive response in vitro, in cell culture, to interferon beta? That can predict poor response in a couple of different studies from Cleveland Clinic and from Italy. What about so-called pharmacogenomics? That is, we all have different genes. We all have different DNA. Would we be able to pick out different mutations on different genes, and those would be associated with differences in response to the different medications? And in fact, I'll show you an example in a second of how that might work with glutaric acetate. I already mentioned these lipid-specific IgM bands. Well, there's also data that if you have a very high level of the IgM bands, you don't respond well to interferon. But I'm going to show you a little bit of data from just a couple of other markers that may be useful. And I would say that in general, none of these are are clinically available today. All of these are sort of being studied now, but this is an approach that is being taken to try and help predict who's going to respond to medications. So this is a slide courtesy of Sual Deeb from New Jersey. I hope he's okay. Haven't talked to him since this week. But they've been looking for years at this, and with very small numbers, just 14 and 11, patients that they define as relapse-free over a couple of years period of time versus having at least one relapse, and looking at various markers that were drawn ahead of time, before the patient started medication. This is with interferon. And perhaps looking at another one of these markers, IL-4, versus, compared to the amount of interferon gamma, that ratio seems to be predictive. Those people with a low ratio do better than those who had a higher ratio. And similar, so-called BDNF, which is a neurotrophic factor, brain-derived neurotrophic factor. Those who had a higher amount of that seem to do better than those with a low amount of that. So these are markers ahead of time that would predict, potentially, response to interferon. This is another one. This is from the Steinman group at Stanford. And they looked at a variety of other interleukins. They thought at first that this interleukin 17 might be a marker, but when they did their follow-up of their own data, they said, it probably didn't really work. But they thought for a variety of reasons that IL-7, a different interleukin, might be helpful. And what they showed at baseline, those individuals who had a high IL-7 level, and as it turns out, all of them had a low IL-17 level, compared to those that had low IL-7 numbers. Then they followed them for 2 years after they got treated with interferon and said, well, what happens to these guys? Well, the people with high IL-7 levels, none of them had any relapses, whereas those with the low IL-7 levels did. So it could be that this is just predicting people who are going to have relatively benign disease, and they didn't have control groups, so this is certainly not definitive. But all those guys with high IL-7s, they had no attacks. This is the glutaric acetate stuff I mentioned, using so-called SNPs, single nucleotide polymorphisms, mutations in different genes. And what this study shows in the so-called Forte study with 1,151 patients, they looked at so-called super responders, people that had no relapses, small changes on their scans. They all started with active lesions on their scan, and a minimal change in the so-called burden of disease over time. And they said, can we identify some panel of gene mutations that might be associated with those people who are super responders versus non-responders? And they identified in a model of 6 mutations, 6 different genes, to try to predict super responders versus low responders. And this model performed pretty well. Picked up about 88% of the people that did respond, and excluded 93% of those who did not respond. That is, really separated out the sort of the good versus the bad response. The problem with this, though, and about 90% of people were actually classified correctly ahead of time based on this. The problem was it only accounted for about 19% of all the people. That is, not only 19% of the people had informative mutations. So although it's very interesting and potentially helpful, it only potentially would cover about 1 out of every 5 patients who have what we would think of as informative mutations. So we need some variation of this, perhaps, that covered 100% of people, not just 1 out of 5. And then finally, monitoring response to therapy. I just want to show an example of so-called CD56 bright cells. We know there's a whole set of markers that people said, okay, you start drug X, and then we monitor this and that and whatever, and it seems to be that those are associated with a good or bad response. Well, that's fine, but that's sort of after the fact. We want to know before the fact, like we were just discussing. The CD56 bright cells might be something that could allow us to learn it very early, though. So this is with daclizumab, a drug that is still being studied. Dr. Vollmer may well speak about it. It's, again, another monoclonal antibody against a different marker. And in these various trials, in this trial, the SELECT trial, 600 patients compared to placebo, 2 different doses of daclizumab taken by a shot every 4 weeks under the skin. And it was highly effective in annualized relapse rate. The number of patients who were relatively relapse-free compared to placebo was higher. Various MRI scan measures were better. The number of patients who had disability progression was less, all like we would want to see. But then they also said, well, what about these CD56 bright cells? These are cells, these are white blood cells. These are so-called natural killer cells, a different class of white blood cell. And when they get exposed to this medication, you see a very modest number, less than 1%, who then go up to 3.6%, a huge increase, a six-fold increase on average in this small little subset of cells. So who cares? So what? Your white blood cells change. So what? Well, the people that had the highest expansion of these white blood cells, these so-called CD56 bright cells, were much less likely to have new disease activity compared to either the people who did expand just a little bit, that is highest quartile versus the lowest quartile, but also compared to the people that got placebo. 85% fewer lesions on a scan compared to the placebo group, which was much better than just any of them separately. So that picked out at 4 weeks and 8 weeks after starting the drug, those people who were going to respond to that drug. So you knew within 2 months if you were going to respond to that drug or not. So I think that we might be wanting to look at new paradigms, new algorithms, new ways of deciding how we choose to treat people. And this assumes a whole bunch of stuff. Approval of all these medications that I've mentioned, some of which will get approved, some of which may not get approved. It assumes that these tests I've been talking about actually are confirmatory. That is, people in multiple other studies show that they are useful, that they become screening tests that are available. It assumes that the insurance companies go along and don't base their decisions based on what they think risks are, what they think costs are, other things, but that they allow us to do things the way that we think is appropriate. They'll certainly change as we gain more information. We'll have newer drugs, we'll have more information about markers, and the algorithms, I'm going to show you a couple that are potential ones, they may well change over time. But these are 3 possible approaches that we could potentially look at. So this is what I would view as what we do today. Today, someone's diagnosed with MS, and in general, they go on the so-called low-risk or first-line medications, interferon, glutaric acetate, or some patients choose to watch and wait. Many of those patients might do well, although quite a few go off the medications for a variety of reasons. And if they do well, though, they'll continue indefinitely. If they do poorly, if they were on glutarimer, then they'll go to interferon. If they were on interferon, they'll go to glutarimer. If they continue to do poorly, then nowadays, oftentimes patients will go to get their JC virus tests checked. If they are negative, they'll use natalizumab. If they're positive, they will now probably use fingolimod, perhaps use teriflunomide, it's now just approved, or they might even use natalizumab for 1 to 2 years, based on that information I showed you, suggesting the risk was very low for 1 to 2 years, but then transition to something else at that point in time. This is sort of, I think, standard of care today. So what are options if we change the way we think? What if we say, well, let's base our decisions not on first line, second line, let's base it on severity of disease. Let's try and use markers to define individuals who have more severe disease and perhaps treat them more aggressively from the outset. And maybe check their JC virus status if they have more severe disease very early, if we believe that natalizumab is a better medication. And if they're negative, put them on natalizumab, or perhaps even rituximab or ocrelizumab, because those medications also will have probably a very low but a definable risk of perhaps having the same PML risk. If they are positive, however, maybe check this IL-21. If that IL-21 works out, and maybe put those patients on alemtuzumab, because we already showed that that's superior to Rebif. And those patients who have less severe disease, maybe just, continue to use glutaric acetate, interferon, try and pick the winners and losers based on these molecules that I mentioned. And then maybe perhaps if someone's pregnant, go to glutaric acetate. If they do poorly, then maybe check their JC virus or their IL-21. And those who have a low risk, go to those medications. Those who have a high risk, go to fingolimod or teriflunomide, perhaps laquinimod or even teclistamab, perhaps choosing those who do well with teclistamab with the CD56 bright cells. So that would be one option. That is, just try and pick people by severity. Or also use severity and still do the same sort of thing with the JC virus status and the IL-21 over here. But as opposed to going to glutarimer, go directly to these medications. Fingolimod's been shown to be superior to interferon. BG12 has been shown to be better than Copaxone. Why not use those first? And then if that fails, then check the JC virus status, check the IL-21 status. Those who have low risk, go to these medications like over here. Those who have high risk, then go to glutarimer or interferon. So essentially flipping the newer medications for the older medications. Or, finally, what about just picking people from the very beginning? If some people believe, not everyone does, that Tysabri, natalizumab is today, in 2012, the best medication, Why don't you just pick people from the very beginning? JC virus negative or positive. Put 100% of people, JC virus negative, on natalizumab or rituximab or ocrelizumab. And if they do well, continue indefinitely. If they need an alternative because they want to get pregnant or they have ongoing disease activity, don't do that well. If they become JC virus, then go to these medications over here. And if they then need an alternative, then go to GA or interferon, or perhaps even check an IL-21 level, and then go to alemtuzumab. The logic being in this case that some are concerned about risk not just with autoimmune problems with alemtuzumab, but also other safety issues that if we use it for a long time might be important, in which case you wouldn't want to use it as a first-line agent ever. I don't know which one of these is right. I don't know how this is going to play out over time, but I think that we should start thinking about using these biomarkers in this way and treating people with more severe disease earlier with more severe and more aggressive therapies. So the paradigm shifts are to use more effective therapies first, probably shifting away from the injectables more towards these IV and oral medications, and the enhanced use of the biomarkers to predict those people that are going to respond to therapy and use the biomarkers over time, before, during, and after use. In order for this to really be successful, though, we're going to need to know better markers that predict outcome, both severe excuse me, and benign, a better understanding of how the markers predict response to the very specific medications, both in terms of benefit and risk. We're going to need more comparative effectiveness research. It's one thing to talk about it, but we have to really compare these drugs. How do we know that if you're a super responder to glutathione acetate, that might be just as good as taking Tysabri? But we don't know that because we haven't actually taken those subgroups and tried to define those in comparative effectiveness research. Perhaps we don't need to use Tysabri. Perhaps if you just pick out the responders, they'll do just as well with a drug that's safer and cheaper. And ultimately, we need better meds, and what I haven't even talked about then is we also need approaches that will both repair and replace damaged nerve cells. Because all of these still work on just the immune system, which is great, but we have a large number of patients who have fixed disability, and we need stuff to help them as well. So thank you very much for coming. I appreciate you spending your Saturday with us. I hope that was helpful, and have a great week.